I'm going to turn this over to Bill Perry as the moderator of our first panel of the day. And there's a panel on many of our clinical programs with kind of a developmental perspective from child through various phases of adulthood and late life. And so I'm going to turn over to Bill. And the way we're going to be doing the panels is for individuals to basically introduce themselves, their programs, perhaps to make one comment of something they may be particularly proud of or some aspirational goal. But we really want to engage the entire audience as much as possible. So, Bill?
So I do want to point out that Sid was not honest with me. He said my job would be very easy. But in fact, to have all of these panelists talk about their great programs in less than 4 minutes is going to be tough. So this is a talk as we introduce more in depth our clinical programs. Almost everyone in the audience has either been part of our faculty or trained at UCSD, and I was looking this morning for a photo of the old Gifford Clinic on 5th and Walnut on the internet and couldn't find one, unfortunately. I'm sure Igor has one, but these are some of the new sites that make up our clinical enterprise. And so this gives you a very broad view of the clinical services that we provide presently. We have an enormous outpatient service now in La Jolla. Of course, our hospital-based services and Hillcrest services, which you heard some about this morning, our eating disorders program, our embedded services, which Pat had made reference to, and then our affiliates, Radies, in particular, of course, the VA as well. And just to show you about what has happened over the 5 years since Igor has established a clinical division, we continue to grow enormously. As Pat had mentioned, our clinical services were really dedicated to serving an opportunity, or providing an opportunity for our trainees to learn. And with this transition and meeting some of the initiatives put forward and the strategic priorities of the health system, we have grown. We now have actually 52 clinical FTE providing services. This just also shows you that this is just work RVUs, but it was a slide that we had available. And with each year, we are expanding and increasing our clinical productivity. We are the fastest growing clinical service in the health system. This is our outpatient. Inpatient has also grown enormously. We have both the 18-bed and 14-bed adult services, one senior service and general adult service. They are at near capacity every day. We have our consult service, which carries in Hillcrest a caseload of over 20 patients a day, and now a growing consult service also at the Jacobs facility. So it's really a very fast and expanding program. One of the things that you'll hear about today are some of the specialty areas that we have really worked on, and we're very proud of all of these. So with that, and because we have such limited time, I'm going to turn it over quickly to Ben Maxwell, who is the medical director of the Child and Adolescent Psychiatric Service, and is going to be the incoming division director starting in July. Is that right?
That's
great.
Right. So if I have 4 minutes, I'd like to just say briefly where we've come from over the past 5 to 7 years, because I think we've gone through a big evolution, and a little bit about what we plan to do in the next 5 years. In 2012, the CAPS unit, Inpatient Child Unit, went from a freestanding hospital in Alvarado to Rady Children's main campus. This triggered a series of events where more and more patients started showing up to Rady Children's emergency department. So we went from about 40 psychiatric patients a month in our emergency department to now we see about 300 to 400 psychiatric patients a month in about 7 years. The hospital obviously saw this and said, oh my goodness, we need to do something about this, because these kids were sitting in our emergency department. It was tough to place them, tough to get them outpatient resources. There's been a lot of push to develop a response to emergency psychiatric problems. And so over the past 5 years, we've opened an urgent care with the Price Family Foundation support in Mid-City. That's an urgent care walk-in model, the first for children in our area. A few years ago, we received a Copley Foundation $5 million support to open a psychiatric emergency department, which is currently under construction, will be adjacent to our general emergency department, a 6-bed unit, to address all of the urgent psychiatric problems that we're seeing in our community and really nationwide. So we've done a lot to figure out how to deal with very acute patients, getting them into our CAPS unit, which is a 24-bed unit, hovers around an average census of around 20 patients. But we've done very little about how do we prevent these things from happening. And so, as I think was alluded to earlier, we are looking forward to the next 5 years where we will do things to prevent psychiatric problems from developing. So mental health integration into primary care clinics is a big push that we'd like to pursue over the next 5 years. Partnerships with local schools, which Desiree Shapiro is already starting a project in regard to creating curriculums for school to encourage psychological wellness, and specifically addressing how are we identifying kids with adverse childhood experiences, or ACEs, so we can intervene early and not only improve their psychological well-being, but as many of you know, improve their physical health through the course of their life. Adverse childhood experiences are associated with not only increased depression, anxiety, and suicide, but also up to a 20-year life expectancy difference from the general population, higher degrees of cancer, strokes, heart attacks, substance abuse, incarceration. So we really want to do a better job of early identification of kids that are at risk for these sorts of adverse experiences and intervening early to improve their resilience.
Introduce Dr. Emily Gray. We were fortunate to recruit Emily back here. She's the medical director of the Child and Adolescent Eating Disorder Program. As many of you know, we have perhaps the preeminent eating disorder program in the country under Walter Kay's direction. So, Emily.
Thank you, and I'm really excited to be presenting today based on the eating disorder program. And I recognize that I stand on really tall shoulders here today because our program is large, and I wouldn't be standing here without the talented and dedicated group of individuals that innovate, are creative, and have helped refine and develop the programs that I'm going to be talking about. And so it's really easy for me to stand here and brag because of the achievements of our program. So just as Dr. Perry had mentioned, our program is internationally recognized for the treatment that it delivers. So, Dr. Kidd spoke about emerging neurobiological findings that are helping to refine and transform our treatments. So bringing the phrase bench to bedside becomes not just a lofty goal, but a practical reality where that is informing our treatments. So by harnessing research, we apply evidence-based treatments for all specific eating disorders. I'm talking about avoidant and restrictive food intake disorder, anorexia nervosa, bulimia nervosa, and as well binge eating disorder. And so as we have all kind of mentioned today, education has been a cornerstone of our program as well. And so throughout our clinical programs, we are incorporating and really helping to disseminate this knowledge to the future in our field. So across specialties, so marriage and family therapists, social workers, psychologists, physicians flock to our program to learn the care that we're delivering. So as I said, our unique programs deliver this innovative care across the age spectrum. So our pediatric program delivers care to as young as age 6, and our adult program treated an individual to the age of 64. So we're really spanning the full age spectrum, as well as the illness severity spectrum. So Dr. Maxwell talked about how Rady's Children's Hospital has been really trying to tackle the acute care crisis for our psychiatric emergencies. And at Rady's Hospital, we have our medical behavioral unit, which is taking care of our most medically and psychologically fragile patients with eating disorders, but also complicated co-occurring medical and psychological disorders. On the other end of the illness spectrum, we have our intensive family therapy week, which I think of it kind of like boot camp for families, where they really get immersed into treatment. So families and patients are there side by side for 6 hours a day, 5 days a week. And this really can be served as an incubator for treatment development. And so our temperament-based treatment, which has been harnessing our research and directly applied to this clinic setting, has been a really great kind of experimental area that has found success. Our PHP and IOP programs, again, span the full age spectrum. We have our pediatric program, our adolescent program, and our adult programs. And any of those program managers actually could be sitting here today and taking my place, as they have been really creative and bringing evidence-based care to these specialty age groups. So we're developing, and we're at the forefront of treatment for developing treatments for ARFID and across the age spectrum, but also dialectical behavioral therapy for our emotional dysregulation patients. And we have tracks. So we're incorporating co-occurring disorder treatment into eating disorder treatment. We work with elite athletes. And so you can start to see, I'm just barely touching on some of our programs, but our programs are really, there's a lot of depth, and we touch a lot of aspects of eating disorders, because unfortunately eating disorders, it's more common to have a co-occurring disorder than just an eating disorder alone. Our physicians provide expert pharmacologic treatments, and we are constantly looking for innovative approaches to how to increase recovery rates from eating disorders. Our staff is amazing, and in fact, our front desk always gets rave reviews from our patients, and you can always speak to a human when you call our clinic. And our intake team delivers free assessments to anyone in our community across the world, so that people can get timely and effective diagnoses and get referrals to necessary treatments. And talking about community, we haven't quite touched on families. And families are an integral part of our community. And families come back to treatment to help serve as mentors. Our patients come back as recovery speakers, and they start to disseminate and advocate on behalf of our patients, because we find that when you have a family member that's impacted, it brings out the lion in a lot of people, and they're ready to fight and push things about policy forward. And so we have a feast program which harnesses that power of our parents in our community and our recovered patients to help them be armed with efforts for advocacy. And again, recircling about to our research. We use our research to collect outcome-based data, and this is one of the things that I'm most proud about. We look at individuals a year after they've left our program, and they're sustaining their recovery, which is unfortunately not the norm in eating disorders. Normally, relapse is more the rule than the exception. However, our programs have found sustained recovery for our patients and families. And so it's really exciting for me to present on all of those fronts. And then finally, I have to put on my business hat and also talk about how we have developed a successful business model. And we have shown persistent growth in our program over the past 10 years. And in fact, over the last year, we showed 22% growth. And about 35 to 45% of our patients are coming from outside of San Diego County to receive treatment. So at UC San Diego, people are coming here exactly looking for the treatment that we're offering. And so I'm really excited to be sharing all of this with you, but it really comes down to our patients. And patients are why we do what we do. And I have one story of a patient, a 6-year-old, who flew across the country from New York because her team had essentially kind of felt like she was a lost cause. They had inserted a G-tube. They kind of said, "You're not really gonna eat again." She had developed ARFID. And she came to our program, and after 6 months of treatment, and I do emphasize it took 6 months, she returned home. She was eating all foods, including fruits and vegetables, and was able to get back into school. And our family continues to send us letters of how she is going to slumber parties, going to birthday parties, and able to have a normal childhood. And that was made possible because of our pediatric program. So it does make a difference for a lot of these families.
So, thank you.
Thank you.
We share in Emily's excitement of the program. I wanted to introduce Nancy Downs, who many of you know, and Nancy is really a national leader in the area of delivering care to college age and college populations. So she is the director, the program director of our college mental health services.
Great, okay, so thank you. So I'm going to try to, in 4 or 5 minutes, describe 4 main areas of our program. I'm going to be talking about our treatment model, the people behind the program, the funding that we've used, and our vision for the future. So, and some of you have already heard me talk a little bit about our model. Basically, we have a population-based model for the 39,000 students that are at UCSD. Those are both undergraduate and graduate students. And there's really 4 tiers to the treatment that we are delivering. The first part is actually a non-medical model. It occurs on campus, and we basically take advantage of the services that are already available through the deans and student affairs, and it's really wellness type programming. So that's where it starts. Then the second tier for the treatment involves utilizing all the folks that are on campus. So these are all primary care providers. They're either at counseling and psychological services or at student health services. And these students, these providers see students who have mild to moderate depression or anxiety. Then the third tier is actually our program that we started back in 2014 with a lot of help from Igor Grant and Bill Perry and other people within the department. We see the higher acuity students who have complex forms of mental health problems. They have a lot of comorbidities. They may have been in the emergency department. They may have been in our inpatient unit, something of that sort. Then finally, at the 4th tier, we utilize intensive outpatient programs, and those include occasionally the eating disorders program. We also are very fortunate and send lots of folks to the care program. As I already mentioned, our NBMU and ED is very helpful with that. We also do occasionally use community IOPs if that's the best fit for the student. Then another unusual aspect of our program is that we track high-risk individuals, and we do that through a variety of ways. One of the ways we do it involves the folks on campus, and we also try to use our EPIC, and we're going to try to do that even more with an upcoming EPIC merger. Some of you may know that the people on campus do not have the same medical record as we do. So soon we will have that, and we'll be able to better coordinate the higher risk students. So that's the model. And just a little bit more about that. So as it relates to that, currently in our college program, we have about 750 students that we're following actively that are at this higher level of care. And we track about 100 high-risk students per year. Then as far as the people, I want to give a shout out to all of our wonderful providers. We have about a total of 5 full-time equivalent providers, but it's spread over about 8 people. And those individuals are Tracy Alderman, Nora Bamidi, Savita Bhakta, myself, Jamie Gannon, Neil Richtan, who's out there somewhere up in the shadows. Let's see, who else is on our team? Jenny Roby, who's one of our graduates, and Jim Schweikert, who's a case manager. I also want to really appreciate the advocates that have helped us put the program together. So some of you may or may not be aware that Joel Dimsdale was really very instrumental in developing this program. He worked at the level of UCOP really prior to 2010 to get some of the funding that we're able to use to have more psychiatrists on campus. I've already mentioned Igor. In addition, we have a wonderful philanthropist, Joe Edelman, who really wants us to make sure we do plenty of psychotherapy. So we've been fortunate to have that funding. And then the chancellor has also been very supportive of our program and has provided extra monies to make sure that we have really good access. I also wanted to mention the mentorship support of Dave Braff, Barb Perry, Steve Schuchter, and Sid Zizik. Lots of times when I'm thinking about how to set up the program or whatever our vision is, I really think back to the training that I had with those individuals. I've really already alluded to the funding. In case you all are interested, that it turns out that we do support ourselves quite a bit by the payments we get from insurance, and we work pretty hard at that. We get about $100,000 a month actually payments received for our program, so that goes a long way. We've got the philanthropy that I mentioned, the chancellor's funds, and the health system. Patty Mason has also helped with some of our infrastructure.
Thank you, Nancy.
Let me just say the vision for the future. So the vision for the future is just 4 things. The first one is virtual reality therapy with Savita Bhakta. She's been specially trained in that area, and we're hoping that we can start that soon. Tiffany Greenwood is doing a screening project on campus to develop a risk prediction model. I already mentioned the EPIC merger. And then finally, Dave Folsom and I are very interested in trying to do even more collaborative care on campus.
Great.
So thank you very much.
Thank you. You've heard reference. You've heard reference to the CARE program, it's the Cognitive Assessment and Risk Evaluation Program. It's an outstanding program that integrates research and clinical services under the leadership of Kristen Cadenhead and of Helene Mirzakanian, who will talk about the clinical.
So I just wanted to talk a little bit about the CARE program, which, as many of you may know, started from a research program. Dr. Cadenhead has been a pioneer in research looking at predictors and early markers of psychosis, and prediction and early identification have also led into us realizing that there is a need for clinical services in this population. And about 5 years ago, Dr. Cadenhead started the clinical branch with the help of the department and the health system. And since then, we have grown a really excellent clinical program addressing the needs of adolescent and young adults who deal with either very early psychotic symptoms or even subthreshold psychotic symptoms, or who have experienced their first psychotic episode. We have a great multidisciplinary team, and we provide a wide range of services. We provide services starting for just regular diagnostic assessment to medication management. We have individual therapy. We have family therapy, different group therapies, and what's really, really unique, I think, and probably still one of the very few, if not the only in the country, we also have an intensive outpatient program that specializes on young adults and adolescents who have a psychotic illness. And it's I think a unique part of our program, and I think has been alluded to a couple of times here, is that we are at an academic institution. We are able to really translate the cutting edge research that we do in our CARE program into cutting edge clinical services. And vice versa, we are able to observe in our clinical population, in our patients, what is needed and what lacks in our research program, and be able to address these needs with scientific methods. So I think that's something that can only be possible at an academic institution, and we're really, really grateful to be in this position. Of course, that also brings with it a huge responsibility. The first responsibility is to the community? How do we, as you alluded to it earlier, how do we expand this? How do we implement this clinical services? And more importantly, the early identification and the prevention of serious mental illness, in this case, psychotic illness. And so a big goal is to actually do wider screenings in primary care settings, work with other clinics in our department to implement what we know in our research program helps in terms of screening, identification, and getting patients in early on so we can help and change the trajectory of their lives. For our clinical services, what we would like to do, and we're in the process of doing, is expanding the services, such as adding a peer support group that we're thinking about. For example, we have an activity space that we are able to, for the adolescent, that we are able to put together through philanthropy money, for example. And so, and hopefully, with the continued support of the department, we'll be able to, in the future, even think about a partial hospitalization program, because we do see the need given the acuity of our patients.
Thank you very much. Unfortunately, Alison Reminick couldn't be here today. She is the program director for the Women's Reproductive Mental Health Program. That program provides expert care for women who are experiencing mental health issues related to pregnancy, childbirth, postpartum, and infant care, bonding issues, and it serves a great need in this community. So I'll move on now to Dr. Maia Dion. Dr. Dion has actually serves in many different roles for us, including our embedded services, but she's going to speak about our adult outpatient program.
Thank you. So I was thinking back to Pat's description of our clinical services back in the day as the Wild West, and we are in the Wild West no more in our outpatient psychiatry services, though certainly continuing to expand. So we now offer services down in Hillcrest, which also serves as a residency training site, as well as up in our La Jolla outpatient services site as well. We offer a breadth of medical evaluation and medication treatment from providers at different levels of medical training. So both, as I mentioned, in the residency level, but also we have now nurse practitioners, and we have psychiatrists who deliver these services. So I remember it was an earlier talk today as we were talking about extension of medical services, and so our department is certainly moving in that direction as well. We offer empirically supported therapies, both individual and group therapy, and in order to meet the growing needs of our UCSD population as it's expanding, we've even opened up, as many of you may know, out in Rancho Bernardo, a primary care setting. Our needs to serve this population's mental health with services is growing as well. So we have most recently in the last year seen expansive growth in our provider pool with the development of PATH core team, and PATH stands for Patient Access Team-Based Health Team, and it meets some of those very important needs. One is access, getting patients in a timely manner, and being able then to implement from our team of multidisciplinary providers that right now has MD and 2 NPs, recently added an LCSW, as well as myself as a PhD provider, where we are able to work together to assess patients' needs and their goals as well for care, to deliver best fit services and triage patients to providers and services at whatever level care that they need, while also bridging them to those services by maintaining their medication management and short-term psychotherapy to get them to wherever it is that they need to be. So as we're moving forward, we're continuing to expand by hiring even more providers to be able to not only meet those patients' needs and getting them in the door, but providing and delivering patient-centered care and working together. And I think that's really where we've seen a shift from this Wild West, where not only were we isolated potentially as a department in a larger health system, but also as providers together within our service. So being able to offer for our providers an opportunity to work together to collaborate on care and be able to make sure that our patients receive services from providers who are best fit for their needs, as well as the level of care that's going to make the most sense for them. So we're tracking folks who are adults from those who are higher functioning in the community and might benefit from more individual therapy or ongoing medication management on a week-to-week or month-to-month basis, to those who may actually benefit more from IOP services or even transition to one of our specialty services. And through this core team, we're able to track them and manage them and offer that support so that we don't just get them in the door and then say, okay, this is where you need to go, and whatever that wait time is, they bottleneck there. We actually bridge them by continuing to have that care, and they may meet with a variety of our team members, so we're really working together in that way. I think that's really innovative and the future that we want to continue to move towards in our department and beyond.
Thank you. Just to add, under the leadership of Ann Bird, who couldn't be here today, but is our medical director of our outpatient services, Steve Coe, the medical director at Hillcrest, and Maia, we have an ambitious goal of being able to have patients seen within 1 week of their call, and what seemed to be an inobtainable goal initially, we're approaching that, and I'm confident that within the next year that'll happen. Most of you who've trained here have spent some time in our adult inpatient service. That was sort of mandatory, and I remember when I first started here many years ago, the average length of stay was quite long, and we had at best 1 clinical FTE. Over the last several years, we have built a hospitalist system. We now have 5 clinical faculty working, and the census, and I don't know if you'll mention that, but the census is really quite enormous. We have the 18 beds, and they're almost full every day. So I'll turn this over to Dr. Louisa Steiger, who is the medical director of what we refer now to what was formerly 8 East, then West Wing, is now the MBMU. Please.
Bill stole a little bit of my thunder because I was going to mention that in the last 5 years under Igor's leadership and that of Bill and Dave, we've gone from 1.5 FTE spread across 3 separate individuals serving the inpatient unit as well as the emergency department and consult liaison service within the Hillcrest Hospital to 5 FTE, which has been wonderful not only for our physicians who are doing that care, but also for our trainees in that they're able to have much more support and attention, as well as for our patients who have us there quite a bit more often. It might sound like a huge jump going from 1.5 FTE to 5 FTE over the course of the last few years, but at the same time, these 5 FTE, about 10% of the department, are accountable for almost 20% of the RVU generation within the department, so we continue to be an extremely busy service. This service, as Bill mentioned, involves the 18-bed inpatient unit as well as the emergency department services and the consult liaison service. So that includes approximately 50 patients a day that are being seen by our team members. These patients, we might forget to some extent, but Hillcrest is actually in what is essentially an inner city, and that is the predominant population that comes through our doors through the emergency department. So the vast majority of our patients end up being those individuals who unfortunately don't have family members to support them or don't have the socioeconomic stability in the community that we might like them to. They also tend to be publicly funded. What this means is that we have, unfortunately, limited options for them in terms of disposition outside of the hospital. And we're hoping, as the health system considers what we're going to do down the line, that we might be able to engage in broader partnerships in the community such that we have more options for these individuals who are publicly funded. In addition to that, we are also hopeful as the health system considers what we're going to do for our psychiatric patients in the future, is that we consider individuals who are perhaps more like those of us in this room, who have some support and who are higher functioning than those folks who often come through our doorstep, such that those individuals would also feel comfortable being in a milieu such as ours. Probably almost every single one of you have at least walked through our unit, and our unit currently does not allow for the ability to triage patients depending on their level of severity, and that unfortunately does not lend itself to a healing environment for somebody who, for example, recently is a leader at the Scripps Institute of Oceanography, for example, being comfortable within our setting for healing. So in that regard, we think that there's a lot of room for growth, for improvement of the care that we provide for different subsegments of the population. In addition, I also want to mention that with respect to the emergency department and those partnerships that we have with the emergency department, there's interest from both that service and the health system to allow for a crisis stabilization unit. So our acute inpatient bed unit has 18 beds, has an average daily census of 17 beds. The average length of stay is between 7 and 8 days, but actually the median length of stay is 5 days, which gives you an idea of how patient flow significantly affects both the folks coming in and the systems going out that we're affected by. So in partnership with the emergency department, we're hoping to improve that patient flow. In addition, we're hoping to move towards more of I've lost the word, but it's sort of a preemptive approach to consult liaison work. Proactive, yes, exactly. I started with a PR. That's a good start, at least. Proactive consult liaison. So right now, we are, while there are a good number of us, we are spread rather thin, and we're hoping that over time we're going to be able to develop a means by which we can more proactively assist our colleagues within the main hospital. We do this to some extent in the burn program that has embedded psychologists that are working there on a regular basis, and we do have very close relationships with, for example, the trauma folks, but it would behoove us and our patients and our colleagues if we're able to more formalize those programs. Then the only other thing that I wanted to mention, Bill, is that while I'm hoping and we're looking forward to the opportunity to broaden the milieu for individuals who are higher functioning, we do perform an incredible service to the community in that we are willing to take patients of all sorts of medical complexities. And for example, the county mental health has to transfer people out by about 28 weeks of pregnancy because they don't feel comfortable having patients there with that level of complexity, which for us is just day-to-day work.
Great, thank you. And rounding out our developmental sequence is, we're very fortunate to have a really robust geriatric psychiatry program with evaluative services, outpatient, intensive services, and an incredible inpatient service as well. So Dr. Kalya Vardi.
So I'm not a natural public speaker, so I did prepare my remarks, and I just wanted to reassure you that I timed it, and it's 4 minutes.
All right.
Okay. So I'm going to be talking about senior behavioral health. It's a clinical division at UCSD that is dedicated to the care of adults who are 60 years and older. Our team includes 6 psychiatrists, all of whom completed fellowship training in geriatric psychiatry and are board certified or board eligible in geriatric psychiatry and general psychiatry. We also have 5 PhD level psychologists, 4 social workers, more than 20 nurses, 10 mental health workers, and an occupational therapist. In addition, we collaborate very closely with geriatric medicine at UCSD. And in fact, our inpatient service is co-managed by a geriatric psychiatrist and a geriatric internist. So the SBH inpatient unit, which is located in Hillcrest, is a 14-bed unit for older patients with severe emotional or behavioral problems. It has consistently led the health system in patient satisfaction, scoring in the 99th percentile on the Press-Ganey surveys compared to similar programs, or national data, I should say. So we admit patients who are cognitively intact, as well as patients with cognitive impairment of varying severity, up to and including patients at the end stages of dementia. So our unique design and staffing allows us to admit patients who have more complex medical problems than would usually be allowed on a psychiatric unit. The inpatient unit, as Dr. Sewell will tell you in much more detail, it was developed over 18 months by a group of clinicians, architects, interior designers, engineers, and regulatory experts. And meticulous attention was paid to every aspect of the design, from the layout to the lighting to the decor, in order to make our unit a safe, comfortable, stimulating, and welcoming environment for all of our patients. As a result, our senior behavioral health inpatient unit has become an exemplar in our field, and it's actually been visited by representatives of over a dozen countries, including Canada, China, Germany, India, Japan, Korea, Mexico, Sweden, and the Netherlands. The inpatient unit is also a core training site for the psychiatry residency program, for the geriatric psychiatry fellowship program, and also for the School of Medicine psychiatry clerkship. At any given time, we can have 8 or more trainees working on the unit, which is by intention, because we know that this experience helps generate interest in working with older adults and also helps prepare the next generation of physicians to care for an aging population, whether or not they make that the focus of their careers. So beyond the inpatient unit, our clinical services include our outpatient clinic, ECT program, the Memory, Aging, and Resilience Clinic, or MARC for short, and our senior intensive outpatient program. The MARC is a world-class multidisciplinary assessment clinic, which is headed by psychiatry, where people experiencing cognitive decline can come to get an accurate diagnosis and evidence-based guidance about what to do next to get the treatment they need, access community resources, and optimize their lifestyle and habits in favor of the best possible outcomes. The Senior Intensive Outpatient Program is a group therapy program for cognitively intact older adults with depression or anxiety. In this program, which is based in cognitive behavioral therapy, patients learn concepts and develop skills to change how they perceive and react to the past experiences and ongoing real-world challenges that contribute to their depression and anxiety. They also benefit from the connections they make with other patients, reducing the stigma, isolation, and loneliness that still too often goes along with mental illness. Across all of our programs, we make a concerted effort to involve family members and caregivers, recognizing the huge impact that mental illness and dementia have on them as well. We also know that involving loved ones makes them better supports for our patients. So I know that I speak for everyone on our team when I say that it's really a privilege to serve this community, and we want nothing more to improve the lives of the people that we work with, and we strive to do that each day.
Thank you. I want to thank all of our panelists, and I just want you to know that Sid and Pat have assured me that at the 100th anniversary you'll have additional minutes. So.
Thanks. I erred in organizing this. I really thought we'd have lots of time for audience participation. We have such an incredibly rich program of clinical and educational programs that we run out of time. Igor.
But I wonder if we could take another couple of minutes here, just because lunch will be all right after this next panel. And if each of your program had one wish for the future, what might that be? I know that's an unfair question to throw at the last moment. Huh? No, but seriously, if there was something
Good point.
that would move your program forward or integrate it or do whatever and if people aren't prepared to talk about it, that's fine.
I'll take the easy
Yeah,
one.
I thought you'd
Yeah.
be, that would be, yeah.
You know, I think this is probably all of us would say this, but our continuum of care has huge gaps in it. And so maybe we have a great inpatient service, but then we can't discharge a patient to a really good outpatient service that's going to be able to maintain the patient and continue the positive trajectory that we might start. And so if we had one wish from the child perspective, it would be really completing out the continuum of care for all payers so that every patient from a 6-year-old with school anxiety to the 16-year-old with early psychosis gets really top-notch care and that they can be treated in an evidence-based approach. Far, far, far too often right now we have an inability to discharge kids from the hospital, inability to prevent them from coming to the hospital. So that's our big wish, and hopefully we'll be able to achieve it in the next 5 years.
We'll make a note of that, and I think it resonates very well with this greater Hillcrest plan that also we've been talking about, where we've identified the boundary issues, the continuity issues are very central. Thanks, yeah.
And I'm so glad to have another opportunity to ask for this, but my greatest wish, as Dave and Bill well know, is to have more social work support for our outpatient clinic. I think there's our patients have a lot of needs, and there's only so much that we can do as psychiatrists and psychologists, and having social work be a bigger part of our teams, I think will help us help our patients even better.
Mine is kind of in line with what was said, and I would say maybe even starting earlier than when they come to us, so the screening aspect of it. If we could, all together screen for the different, psychiatric conditions and be able to then have a really smooth way of transferring care for these patients, then I think that would be fantastic.
Yeah, and I would add to that, I would love to have outcome measures. We've been working on that for a while, but we keep kind of getting snagged. I would love to have regular outcome measures, especially in the outpatient setting.
Well, you've just volunteered yourself to work with Chris Longhurst and everybody else, right? To do that, yeah.
My biggest wish is very concrete. I want lots more space. I want more beds. I want more treatment rooms. I want more interview rooms. I would love to have space for perhaps a community-based model, perhaps of the care program or other continuities of care, like the senior behavioral health program has. I think that would be fabulous for our program.
I will ditto the space request. But I think that what we've been really working towards in outpatient psychiatry is this team-based model. I'd love to see that expand. We work in an integrated health system, and patients' needs and their mental health needs are often related to other areas of need that are addressed by other providers in the system that we work within, and thinking about us as being a team in a broader sense, and an interdisciplinary setting for these patients, and coordinating more effectively with our referring providers who are also serving our patients.
My wish is very similar to what everybody has said, but as we are a center of excellence for eating disorder treatment, we do have gaps in our continuity of care, and so filling those gaps with either residential treatment, but then also knowing that a large portion of our population that we serve does not reside in San Diego, how to boost their home communities to be able to support and maintain and foster their recovery. So looking outside of San Diego as well.